Degenerative and inflammatory diseases of the spine make up a large majority of patients for spine surgeons. A thorough understanding and foundation of these common disease processes is essential prior to formulating effective treatment plans for these patients. Lumbar spondylosis begins with disc dehydration and degeneration with age and repetitive axial loading. As a result, the shock-absorbing effect of the discs decreases and more forces from the axial loading are transmitted to the end plates and posterior elements. End plate changes occur, including inflammatory modic changes and end plate sclerosis. The motion segment is eventually stabilized by osteophyte formation across the disc space. Another consequence of disc degeneration is loss of lumbar lordosis as the disc space is flattened. This shifts more stress to the posterior elements and results in facet hypertrophy and laxity. Facet laxity combined with degeneration of the annular fibers may lead to spondylolisthesis as they lose their ability to resist translation. Asymmetric disc degeneration may also lead to coronal imbalances and deformity. Symptomatic lumbar stenosis, which forms secondary to lumbar spondylosis, is often multifactorial and the result of disc protrusion and herniation, ligamentum flavum hypertrophy, spondylolisthesis, facet hypertrophy, synovial cyst formation, and posterior osteophytes. This may lead to a combination of radicular and claudicant symptoms secondary to stenosis in the lumbar spine. Myelopathic symptoms may be present in the setting of spinal stenosis at or above the level of the conus medullaris. We can further discuss the process of lumbar spondylosis in the context of biomechanics of the intervertebral motion segment. Compared to the intervertebral disc, the vertebral body undergoes remodeling to effectively combat axial loading by creating vertically oriented columns of medullary bone. In the absence of osteoporosis, the vertebral body may continue to effectively handle repetitive axial loading with age. The disc, however, loses its ability with age to handle these repetitive stresses. In a disc that has undergone minimal degenerative changes, the intradiscal pressure is symmetrically distributed with axial loading. However, when there are asymmetric distributions of pressure, such as axial loading with bending or extension, this will lead to migration of the nucleus pulposus. For example, the forward flexion results in dorsal migration of the nucleus pulposus, therefore moving from an area of high pressure to an area of low pressure. During this same process, the annulus bulges on the side of the disc space opposite to the side of migration of the nucleus pulposus. These repetitive stresses from the annulus leads to periosteal bone elevation on the vertebral end plate and eventual osteophyte formation across the motion segment. In midlife, as the nucleus pulposus continues to desiccate, the intradiscal pressures may drop centrally in the nucleus pulposus but remain high peripherally in the annulus. End-stage degeneration will result in persistently high pressures in the fibrocartilaginous scar that evolved from further degeneration of the annulus, along with extremely low pressures centrally in the near completely degenerated nucleus pulposus. These pressures may actually drop below zero. As opposed to the spondylitic process, which is defined by non-inflammatory degeneration of the intervertebral disc, inflammatory spinal arthropathies, such as rheumatoid arthritis, are autoimmune conditions that involve both synovial and ligamentous inflammation and destruction that predominantly affect the cervical spine. Common pathologies that are brought to surgical attention include atlantoaxial instability secondary to transverse ligament insufficiency. This may lead to atlantoaxial subluxation. Surgical treatment is atlantoaxial fixation. Pannus formation at the C2 odontoid may occur as a result of mechanical instability. Pannus formation has been seen to resolve in many instances following C1-2 fixation. An exception to this would be a pannus that is predominantly calcified. Basilar impression is another pathology seen in rheumatoid arthritis patients that involves upward migration of the odontoid into the foramen magnum with ventral compression of the brainstem. This is often treated with a combined anterior odontoidectomy and posterior occipital cervical fixation, but may be treated with posterior occipital cervical fixation alone in the absence of severe ventral brainstem compression. Some surgeons have treated basilar impression successfully with a C1-2 posterior fixation with bilateral facet spacers. This is because many have theorized that basilar impression is secondary to destruction of the C1-2 facet joints. Subaxial cervical spine involvement include subaxial cervical subluxation secondary to ligamentous destruction and laxity, as well as facet destruction and laxity. These patients are more susceptible to spinal cord injury in the setting of trauma given increased cervical instability. Axial spondyloarthropathies are of particular interest to the spine surgeon due to their propensity to autofuse over several motion segments, creating an unstable lever arm in the setting of trauma, requiring surgical fixation. Compared to a normal spine without autofusion at several levels, even 1 and 2 column injuries are less likely to heal. Diffuse idiopathic skeletal hyperostosis, or DISH for short, is another entity similar to ankylosing spondylitis in the fact that it may autofuse over many motion segments and create challenges to the spine surgeon. There are many radiographic similarities and differences between ankylosing spondylitis and DISH. Early and bilateral sacroiliitis and fusion of the sacroiliac joint is a hallmark radiographic finding of ankylosing spondylitis that effectively distinguishes it from DISH. Ankylosing spondylitis forms broad syndesmophytes that bridge circumferentially around the vertebral body. As these fusions across the disc space occur, they create the bamboo appearance of the vertebral body. In DISH, there are anterior bridging osteophytes. However, the vertebral bodies and end plates are largely preserved compared to ankylosing spondylitis. The process of spondylodiscitis that occurs in ankylosing spondylitis causes loss of disc space height compared to DISH, where the disc height is largely preserved. The normal configuration of cervical lordosis is in part due to increased disc space height in the ventral portion of the disc space. The cervical spine will develop a straight configuration and eventually a kyphotic posture with degenerative disc disease. As a loss of cervical lordosis occurs, the moment arm is offset ventrally from the instantaneous axis rotation of the cervical vertebral body, leading to an increased bending moment which perpetuates cervical kyphosis. In ideal contexts, ventral vectors of compression, such as herniated discs, are best approached by an anterior approach, which could be an ACDF, cervical corpectomy, or artificial disc replacement. Posterior vectors of compression, such as predominant ligamentum flavum hypertrophy, are best approached via a posterior approach, by a posterior laminectomy infusion, or cervical laminoplasty. It is important to approach each patient by a case-by-case basis, including special considerations such as the presence of cervical deformity, ossification of the posterior longitudinal ligament, or OPLL for short, and multi-level compression. OPLL has very complex anatomy as well as a very high risk of CSF leak from the anterior approach and may require a posterior decompression despite significant ventral compression. There may also be contraindications to certain approaches, such as the anterior approach in the setting of previous radiation treatment to the neck. Other conditions require a combined approach. For example, severe cervical kyphosis may involve draping of the cord over the posterior aspect of the vertebral body, leading to myelopathic symptoms, and require a combined anterior and posterior approach, depending on the patient. The various etiologies of axial spine pain have different forms of management and must be carefully differentiated from each other prior to creating a treatment plan. Mechanical axial spine pain is characterized by deep and agonizing pain that is worsened with axial loading and is improved with unloading, meaning that the patient should be able to find a comfortable position, such as sitting or laying down. Inability to find a comfortable position questions the nature of mechanical back pain and is a negative predictor to good outcome in fusion surgery. Myofascial pain is the most common axial spine pain and is characterized by paraspinal muscle tenderness. Compared to mechanical back pain, these patients may be unable to find a position of comfort. However, the pain should also worsen with axial loading. Inflammatory axial spine pain, such as that associated with ankylosing spondylitis, is characterized by either early morning or late night back pain that improves with movement. Chronic pain is more inconsistent and poorly characterized. There may be a burning or lancinating component, and this type of pain is associated with failed back syndrome. Many of these patients may be candidates for neuromodulation, including spinal cord stimulation.